which I get is you put the strobe inside and you see whether mucosal waves are present or not present. This is the most common thing which we are seeing, but there is much more that we see in a stroboscope compared to just mucosal waves. Just seeing mucosal waves and saying mucosal wave हाँ दिख रहा है, all of us can see. Even a non-ENT surgeon, if you show them the stroboscope, he will see mucosal wave and he'll say yes, present or not. So our role as a laryngologist or as a specialized ENT surgeon is to find out more. It is an investigation we have, it's a machine we have spent so much money on. So let us make a maximum use of this machine and try to diagnose most of the pathologies. I don't think anything can be missed out if you do a proper thorough stroboscopy. It is just that you need to have a good instrument. Now, one is there are a lot of patients which come to us with hoarseness of voice. You put a VL scope inside, you see a vocal nodule, vocal polyp, then many of the ENT surgeons say that what is the need of using a stroboscope? Why do you need a stroboscope if you are seeing a clear-cut vocal nodule, vocal polyp or any other, any such pathology? So believe me, even in a simple vocal nodule or even in a simple vocal polyp, if you put a strobe light inside and if you keep doing this regularly, you will see that there are so many times you will find some other pathologies in the upper lip of the vocal cord, middle lip or the lower lip of the vocal cord. So very carefully when you put the strobe inside, see to it that you see the entire vocal cord which is seen. We have a paucity of time, but I would like to just, it is a very important tool for the voice assessment. No voice assessment is complete until and unless a stroboscopy has been done. Just putting a rigid scope inside and seeing whether vocal cords are mobile, not mobile is not correct. So believe you me, if you are doing a proper ENT practice, invest in a stroboscope and you will find out more pathologies. The patient will be more satisfied because nowadays private patients, they read and come whether you have the proper instruments or not. So we need to be thorough in using and assessing stroboscope. Principle, I'll just leave it. It's just more theoretical. We'll go. So it's just like strobe light. Now the idea is, why do we need a strobe light? So vocal cords are vibrating very fast. I'm sure all of us know. And these vibrations cannot be seen. When we put simple light inside, we just see opening and closing of the cords. Opening and closing. The most of the voice generation happens. Understand this very clearly. The voice generation happens during the closed phase of the vocal cord. Open phase is just for breathing. The voice generation happens during the closed phase, and in stroboscopy, we are assessing the closed phase. What all changes are happening in the vocal cord during the closed phase. So in this closed phase, what all changes happen will give us so much of information about vocal cords that you will feel that we all will miss it when we are doing a simple VL scopy. So we are assessing voice. Voice happens in closed phase, so we need to do a thorough assessment in voice. I am sure most of you would have seen such cases where the patient has a bad voice. You put a VL scope inside, vocal cords appear normal. But unless you do a stroboscope, we will find many pathologies inside. So the point is, these are all theoretical, a long lecture on this, but to understand this, if vocal cords are vibrating very fast. So imagine it's a dark room where we have a ping pong ball, and I am throwing a ping pong ball from one center to other center. I would not be seeing anything. If it's a well-lit room, if I throw a fast-moving ping pong ball, it hits down, it hits somewhere, so we will see 1, 2 and maximum 3 points of contact. But if I want to see where all did the ping pong ball went up, down during reaching the entire station, I will need some other investigation or some other way of evaluation. So along with the speed of this ping pong ball, there should be light which is flickering. So same speed, jitne speed se ping pong ball is vibrating, the same speed se if I have a light which is closing on, which is switching on and off, I would be seeing the movement of the ball in a slow motion. Exactly this is required. For example, seeing a fan. If it's a fast moving fan, someone asks you kitne blades hain, we won't be able to tell. It can be 2 blade, can be 3 blade, can be 4 blade. But if we are using a flickering light on it and we can see the movement of the fan, we can say whether there are 2 blades, 3 blades, 4 blades. So exactly same principle is being utilized, that any fast moving object, especially vibrating object, if we are throwing light at the frequency of the of the movement. So if we are throwing the light at the frequency, we will find that object is stable. So if the vocal cord is moving at say 400 per second, and if the flickering light is at 400, we will find vocal cord stable. This is not what we want. We want to see a slow movement of the vocal cord, and for that we need that the frequency of the strobe light should be slightly less than the movement of the vocal cords. So first point, take home message is, in stroboscope the frequency of the flickering light should be slightly less than the vocal cord movement. Now who will decide? How do we know the frequency? This machine will decide. So the moment I use the mic, the moment I use the mic in my while assessing, and I say I am seeing 190 here. This is F0. So fundamental frequency of my voice. So any voice assessment should start with noting down the fundamental frequency of the patient. Generally, mainstream it is around 1. Hello, 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 hello. So in males it is around 100 to 120 in males, and females it is around 200 to 220. So 120 males, 220 females. Easy to remember. So first of all, as I said, you need to understand how fast the vocal cord is vibrating. ये कौन decide करेगा? Machine decide करेगा. So the moment my voice is being recorded here, it shows. If I am saying it goes to 400. So you see the frequency of the vibration are increasing. If I am saying it is coming down. So the lower the pitch of the sound, lesser will be the frequency of vibration. This is F0. So first point that we note in case of a stroboscopy is noting down the F0 of the patient. वो note कर लिया. Now it is the job of the strobe. So having a good strobe, good company. I am not supporting a successful company, but having a strobe of a good company, because this machine decides it has to give the strobe light should be slightly less than this F0. It will vary from person to person. 120 for me, 150 for him, 150 for somebody else. So this machine has to give the strobe light slightly lesser than this F0 frequency. And that is how a good company, investing a strobe for a good company is very, very important. There are many companies making it, just see whether if this is being followed or not. The first point is noting down fundamental frequency. They will be changing. Today if I am saying it is 120, if I speak too much, my voice becomes hoarse, it can come to 110 also. And if my voice becomes shrill, it can go to 200 also. So first point is F0, all of us should be noting down, and then that happens. I'm skipping the basic physiology part. Now coming to instrumentation. First of all, for doing a stroboscopy, the first thing that is required is पेशेंट. पहले पेशेंट होना चाहिए. पेशेंट होगा तभी हम बाकी चीज़ें कर सकते हैं. सो फर्स्ट इज वी शुड हैव अ पेशेंट विद चेंज इन वॉइस. सो इफ वी कीप गेटिंग फ्यू पेशेंट विद चेंज इन वॉइस एंड यू रियलाइज दैट आवर VL scopy is not able to assess clearly, we need this machine. So machine has got two important points we need to understand. We have a monitor which is there. We all should understand is a good medical grade monitor should be there, because we are assessing very micro part. So good monitor should be there. There should be a processor which is light source. So processor which will be giving the strobe light, which will be giving analyzing the movement of the cord and the strobe light. So strobe light directly can count. So strobe light, the processor and the monitor. These three things are the part of a stroboscope. Any machines, that company or any other company, they will be having these 3 points. Then there are 2 things. There should always be a mic which should be attached, and the collar mic and the simple mic which is there. Anyone can be used. This is to know the fundamental frequency. Now there are 2 things. Rigid लाना है या flexible लेना है. Again, very, very important question. Should be used with a rigid flexible scope with a stroboscope, or you want to have a flexible scope with a strobe? If we are beginner into ENT, I would suggest go into a rigid scope, because rigid scope gives much more information. Maybe many of you will counter me, but rigid scope will give more information compared to a flexible scope. Flexible scope is important for functional assessment. If I am assessing a singer and I want to see how the singer goes in a higher pitch, lower pitch, which all rag he is getting problem, I will put a flexible scope. But in a rigid scope, you have a rigid scope here. They are not it. They don't have it. But rigid scope is a 10 mm scope. There are 7 to 10 mm scopes are available on different companies. Buy a larger. We all are used to using a 70-degree scope. हम सबको पता है 70-degree scope को DLS कैसे करना है. We've been doing it since our residency days. Using a 70-degree scope, all of us know. And now when we use a 10 mm scope, yes, they have it. So when we use a 10 mm scope, this will give us a wider picture. हमको क्या चाहिए? We want a wider picture. Whereas we have seen the vocal cords, but we need to see a wider picture of the patient, of the vocal cords, and so a rigid stroboscope is very, very important. I tell all my students and the juniors that even if you have a flexible scope with strobe, always use a rigid scope, because it gives you a magnified view. Second point, if you see a flexible scope, If you have a flexible scope, most of you have been doing flexible scopy, sir just demonstrated a bronchoscopy, flexible bronchoscopy. Now this has got a chip on the tip camera, right? The chip on the camera is here. So when for this to assess, I need to go very, very close to that structure to assess. We have a write-up from paper is there. So if we have a write-up, they have given their own paper. I am not promoting them. Okay. So if we have if we have a close thing here, if you see carefully on the monitor, when I go close to it, you will find a fish eye effect. What do you mean by fish eye effect? That my eye is very, very close. If you are watching, it is just like watching a film. You want to watch a film from the front row or last row. All of you want to watch a film from the last row because you get the entire view of the screen. I can watch the film from front row also, but I have to see eyes very, very carefully. I will not be able to see it. But that effect is there. My eye, this is my eye. My eye is very, very close to that structure. So the vision I may not be completely clear or you may miss out few things. So you have a flexible scope, use it with the strobe, but don't forget to use a rigid scope. A rigid scope is very, very essential. And in case if you don't have a 90 degree or a 10 millimeter, use a 70 degree scope also. But use it, get a wider magnified view. The second point I would like to take home after this is rigid scope gives you a lot of information, but flexible scope is important because when you assess the function of the patient, when patient says I can't sing in a high pitch, or when I'm throwing dialogues to a larger audience, my voice gets bad. Normal talking is good. In those cases, functional assessment becomes very, very important. So we have the three machines are there. We have a rigid scope, flexible scope. Now, just understand, this is what we see is a movement in slow motion. It is not actually a slow motion. We are not seeing a slow motion. Slow motion is if I am running, or if you are seeing a YouTube video, or you see any video on a mobile and you reduce the speed. That is slow motion. That is slow motion. This is not slow motion. This is a perceived slow motion where you are seeing the entire range of the waves. We are seeing a part of one wave, part of second wave, part of third wave, and this machine makes it complete one way. So it is a perceived slow motion that we are seeing in the strobe. It is not a slow motion. Till now we have understood two main points. The F0 is important. Second point, rigid scope is as important as flexible. Now, कब करना है stroboscope? Believe me, all patients with voice change should be strobed. All patients with voice change should be strobed because it gives us lot of assessment, and patient has obviously taken some basic treatment from a general practitioner, physician, or from us only, maybe with antibiotics, decongestion, steroids, and now he wants, I want my voice back. So all patients of voice change should be strobed, especially if there is some restriction of too many patients or money is a issue, then those patients in which change in voice is there, but VLS is not giving anything very specific, or we are suspecting malignancy, or we are suspecting some cyst-like condition, strobe should always be done. So it gives us pliability. Vocal cord movement तो हम सब देखते हैं, but vocal cord का when it is in, as I said, it is in closed phase that we are assessing. So the pliability of the cords is very, very important that we assess when we are doing a strobe. And yes, one important point. Most of us, what we do is we put the scope inside the mouth, and we tell the patient to say just giving you some information. For more information, we need to have this was a modal phonation. We need to have a high pitch phonation, we need to have a low pitch phonation, and we need to have a varied phonation. We need to say E, then E, E. This is 3 points, and 4th point is E, E. So all these 4 points should be there when you are assessing the vocal cords, because our aim is to see the pliability of vocal cord, and until and unless you test the pliability. So testing pliability is when you speak on a high pitch, low pitch, and a up and down pitch. This will test the pliability of the vocal cords. So assessing the voice in all these 4 methods is extremely important. That is not only modal phonation, but high pitch, low pitch, and the up and down movement. And what to see? So one thing, fundamental frequency, I've already told you. All of us know mucosal wave. ये दो चीज़ mucosal wave तो हम सबको पता है कि स्ट्रोब में क्या देखना है, mucosal wave देखना है. All of us say that. So mucosal wave present. I'll just take 10 minutes more, 5 minutes more. So mucosal wave should be seen, and then we have to see these 4 things. It is these 4 things which we always forget to mention. When you see the strobe light, we always see the mucosal wave, फंडामेंटल फ्रीक्वेंसी आई हैव टोल्ड यू, बट दीज 4 थिंग्स वी ऑलवेज फॉरगेट. तो ये हमारे नॉलेज में थोड़ा गैप रह जाता है, ये हमारे नॉलेज में थोड़ा गैप रह जाता है, इसलिए हमको ये GAPS ये हमारे गैप्स को भरना है. सो वेन एवर वी आर अबाउट टू राइट दी स्ट्रोबोस्कोपी फाइंडिंग म्यूकोजल वेव लिखने के बाद हमारे नॉलेज में क्या गैप्स रह जाते हैं, ये गैप्स को हमको फिल करना है. व्हाट आर दिस गैप्स? इट इज द ग्लॉटिक क्लोजर, it is the amplitude, it is the periodicity and the symmetry. Very very important that whenever you write a strobe report, ये पांचों छह चीज़ें should always be there, that mucosal wave, frequency and the gaps. ये छह चीज़ें आपकी रिपोर्ट में आ गई. It means you have assessed, you have seen the vocal cord properly, and then your report is fine. If a patient goes to a laryngology center anywhere in the world, he will be the doctor will be happy that my patient's voice has been very well assessed. So these gaps and frequency and the mucosal wave, ये छह चीज़ें आपकी रिपोर्ट में आनी चाहिए. अब इसमें देखना क्या है? व्हाट इज फ्रीक्वेंसी? आई हैव टोल्ड यू. वेव्स आई हैव श्योर ऑल ऑफ यू नो. मेल्स फीमेल्स आई हैव डिस्कस्ड ऑलरेडी. नाउ ग्लॉटिक क्लोजर. सो व्हेन वी आर पुटिंग द वोकल कॉर्ड्स इन द माउथ, आई एम टॉकिंग ऑफ व्हेन पुटिंग द स्कोप इन द माउथ, इट शुड बी. सो फर्स्ट इज हाउ टू प्रिपेयर द पेशेंट. अगेन, सीइंग सच अ लार्ज स्कोप putting in somebody's mouth, first of all any of us will have apprehensions. Okay, I am coming to this point. Theory we can read, but putting this scope, doing this scopy, lot of time the patient has got lot of gag. So how to prevent this gag? Lidocaine spray is one way. We do use that, but does that relieve the gag always? No. Lot of time patients have this gag reflex. So better way is, instead of you holding the tongue, tell the patient to hold his tongue himself. So अगर patient अपना tongue, because I holding somebody's tongue, chance of gag is more. Patient using his own hand to hold the tongue, the gag reflex will be less. Secondly, hold the tongue of the patient before putting the scope. Tell him to say e, different phrase. So without putting the scope, let the patient know what is to be done. Mostly what happens is, I have seen juniors residents doing, they put the scope inside, patient is gagging and then they say e bolo, e bolo, e bolo. Patient is suddenly मुंह के अंदर है and e बोलना है. उसको पहले बता के रखो कि टंग ऐसे बाहर रहेगा, ई बोलना है इन डिफरेंट वेज. तो पेशेंट इज मेंटली प्रिपेयर्ड कि द स्कोप इज गोइंग इनसाइड एंड देन यू हैव टू से दैट द फोनेशन. Glottic closure, majority of time, see one complete cycle will have all generally 10 cycles are seen. Majority of time it is an open phase. In certain conditions there is more closed phase, especially if patient is having a condition where he is having too much of wave when he is talking. In that case, too much of adductions are there. So closure phase will be more. But when he is breathing and he is trying to talk more of open phase will be there. So in the breathy phase there will be more of open phase, and when there are spasmodic conditions there will be more of closed phase which may be present. Then not only the closure, it should see the way in which it gets closed. It's the anterior closure which is lacking, the middle closure lacking, or the posterior closure lacking. Posteriorly can be a granuloma, middle can be a nodule, anteriorly can also be a nodule. So which part the closure is not correct, that we need to assess. Then comes symmetry. Remember, symmetry is something that we all of us miss it. And we all of us get confused between symmetry and the amplitude. Let us for once and final time clear what is symmetry and what is amplitude. Symmetry जो है हम दोनों chords में check करते हैं. Symmetry we are checking into vocal cords. All of you are now understanding that the assessment of stroboscopy is during the closed phase. Open phase में हम नहीं check कर रहे हैं. Assessment of vocal cord is during the closed phase and the movement of the cords which are coming. So symmetry is when the movement of the vocal cords are happening from the center. Both the vocal cords, how much excretion, how much out they are moving. So symmetry is for both the vocal cords. It should be from the center to the lateral part. So when we say symmetry, both the vocal cords are symmetrically going out or not going out. That should be our word that we mention. So in our strobe report, there should be F0. There should be about glottic closure, complete, incomplete, more open phase, more closed phase. Third point, symmetry. Whether both the cords are opening symmetrically or they are not opening symmetrically. There are various conditions where the symmetry will be affected. Again, not going to details of the pathology, but we should understand to see the symmetry. That is, both the vocal cord should be analyzed together. That is symmetry. And what is amplitude? Amplitude is for one vocal cord. So we see how much during the movement of the vocal cords, how much outside one vocal cord is going. If the outward movement should be more than half or more than almost equal to size of the vocal cord. So amplitude is what we see is how much outside one vocal cord is moving, and symmetry is from the midline both cords whether they are equally moving out or not. So amplitude is for akela, amplitude is akela vocal cord, one vocal cord we are checking, and symmetry we are checking for both the vocal cords. So symmetry we should be talking of amplitude, and there are conditions where the amplitude gets affected, there are conditions where symmetry gets affected. Obviously we don't cover the entire detail which condition happens when, but understand. And the important point is, when you have this system, you record the voice, high pitch, low pitch, and the up and down pitch, and in all the movement look for this 5 things that we see inside. Then there is periodicity. बहुत मुश्किल है check करना. To check periodicity, no one can with authenticity say that periodicity is very, very good because or is normal, because for periodicity we are seeing whether the waves which are coming or the movement of the vocal cord which is happening, are they happening periodically in both the time equally or not. Now try to understand what I am trying to say. Periodicity is, क्या वो टाइम से, जितने टाइम से मूव करना चाहिए उतने टाइम से मूव कर रहा है कि नहीं कर रहा है. So a better way to do is, if we can adjust our strobe light accordingly, so it is a visual perception that we are having, and we see whether the waves are coming together or not coming together. So periodicity is one very, very important point which you understand. If you don't understand, if we are not very sure, you can write periodicity query normal, because most of times any laryngologist who is doing so much of study in this will understand that giving a report on periodicity is not very, very accurate. Just writing it normal is not correct. If you write query normal, or if you are very sure, then write. And amplitude we have discussed, and lastly mucosal wave, our favorite. We all of us know that as the vocal cord they vibrate, the mucosa will move up and down, and mucosal waves will be seen, which is the most important part. And based on some part moving more, moving less, any pathology, even simple vocal nodule, vocal polyp, do see the mucosal wave, because even a simple vocal polyp will give you whether waves are present, not present, and whether you should be if it is a simple nodule or a polyp with absence of mucosal wave, definitely take little bit wider margin to take for a biopsy. If waves are present, then remove it like any other method. So it has its own limitation. It is not a slow motion. It is generally a perceived slow motion which is there. And now rigid flexible we discussed already. One point I need to assess is when we are using flexible. Last point of my talk. Now flexible scope when we are using. It is important. Now what happens is, if a patient is sitting in up, right, we cannot do it just show the patient. So what happens is, I have sprayed the patient's nose, I have sprayed the patient's mouth. So don't spray too much. I am sure before spraying on the patient, when you do for the first time, spray on your nose. See how irritant it is. I have done this. I am sure I want all of my students to do a spray inside. It is a very irritative spray. So spray, just one spray in the nose. Tell the patient to hold his breath. What happens is, we are spraying, he breathes inside, very, very, too much of irritation is there. So tell the patient to take a deep breath, hold it, and as he has held it, press it. Spray the lilocase, and then breathe out. This will give us limited, very, very less amount of irritation. One spray, one spray. Tongue outside, say ah and one spray, because ah will open the palate and one spray should be there. So just 3 sprays enough. You can put some albuterol drops. Now, lot of time what happens is, when we are putting the scope inside, we are holding it like this and it goes inside. We are putting the scope and it goes inside. All of you are able to understand what I am saying. We all do the same thing. हम यहाँ से पकड़ते हैं, we are straight inside, we go inside, and my left thumb is which is controlling the movement of the stroke. So this goes inside. We have many different uses. So as we go inside, okay, I want to make a small point here. So when we are putting so one important point when we are doing a flexible scopy, generally what happens is in straight. So when a patient is sitting, the position of patient should be same as what when we use it in real scopy. What happens is patient is sometimes extended, sometimes flexed. All of us are doing real scopy for foreign body coin removal. Always put it in the same position. The patient should be flexing at neck, extension at the head, or patient tell him how does he smell something. So as the patient smells something, in that way his neck should be slightly flexed at the neck and extended at the head. This goes inside. This is one important point. Don't switch on the light. Keep the light on. Right on. So I want all of you, you know what to see. I'm just saying how to hold it, because sometimes this is the problem. What happens is there are two angles which are formed. One is this angle. When I'm holding it here, this angle, this curvature, which all of you try to understand this curvature which is formed. So when my scope goes inside, as my scope goes inside, all this is fine. So you see now when I'm holding it, because of patient movement or initial days, okay. As I go inside, now what happens is we need to see the entire area. Now it's flexible. Because it's flexible, I will see the tonsil, the base of the uvula, the base of tongue, and I go down. Now the problem comes. Now if I have to move it, we do this movement. So when we are doing this movement of my hand, the movement is not reaching the tip. So many times we are seeing asymmetrical vocal cord, we don't see very clearly. So see, when I am moving this, now when this curvature is there, when I am moving, the movement is not good. But try to keep this straight. Try to keep this angle straight when you are doing a scope. So when I move it, the entire movement goes down. With the flexion, the movement will not be as much as I want, but when it is straight, the movement gets delivered on the tip fast. So, point here to make is, don't keep this angle too much, because when this angle is too much, this movement is not getting delivered, because I am holding it here. This movement is not getting, you see the tip is not moving much, but when it is straight, the tip movement is more. 1 point. Second, all these scopes, flexible scopes, are a modification from the esophagus scope which were made. All these scopes which are made are the modifications after the esophagus scope was made, and then they thought, okay, we can see larynx also with this. So all these are, see your esophagus scope is how he is putting an esophagus. He will hold it like this. He will hold it like this, and he will go inside like this. So this gives him a movement. Elbow movement also is there, and with this elbow, you see esophagus scope. You see how much you are doing it also. This elbow movement gives them the entire range of movement to be seen. So you should try this movement also if you want to see. So normally when we see, the cord will be anterior, but try to rotate it and make it entirely in this manner. This will give you a picture of entire anterior part, posterior part, completely reversing. The point here is, when you are seeing a patient of subglottic stenosis, sometimes this movement inside will not give you the entire picture. So when you rotate it, it will give us an entire narrow band. Anterior narrow band is present, the posterior band is present. So try to do our movement generally at the wrist, which is good, which is ideal. We should be doing this only. But if you want to have a better assessment and do a better way, try to do an elbow movement and see if you can rotate completely. This is one way which all of you should try, and you will see that some information, especially the subglottic area information, we can get better. So point is, the angulation should be as less as possible, and as you go inside, try to rotate, and along with the wrist movement, try to use the elbow movement also. For this, sir, patient may bite it. We don't want to lose.
You will not get the bird side.
Yes.
When you pass it from the nose, as he said, you get a food.
Yeah.
Pass it from the, it's like a gastroscope. When you pass it from the mouth, you will immediately reach to the larynx. You will not let other.
In newborn, we do it when a case of laryngomalacia or some comes where the nose is very small. We put it from the mouth because they don't have teeth.
Do you advise any glycopyrrolate or something before use? Because I find many bulky patients like those who are like teeth,
Sir.
they have a lot of saliva in the throat. That hampers a lot. So I prefer sometimes to give the glycopyrrolate before doing all this.
I have not tried that. We can always try glycopyrrolate 1 milligram tablet. It comes, and I think we can try that. A good option we have. We'll try, and I'll give you update in next Mentcon concept how it worked.
Some saying that you can have a cycle of
Yes, sir. But the view gets affected, sir, because the moment you reach inside, you see epiglottis. So that is not what we want. We want a wider view. We want to see the entire oropharyngeal part also. So obviously somewhere it is chymography, high speed camera is always there, and that is all that I had to say for the stroboscopy. Any questions I would like to take about stroboscopy? Anyone? Yes. Any questions from anyone? Anything I missed out? Anything I missed out? I should have said more. Or
No, what problem with the flexible, your maneuverability and your easiness is much better for.
agreed. Yes. Yes.
If you have
any video of stroke
I can show in a live patient here what to analyze.
because everybody will have
Yeah, we can do that. Anybody? Yeah.
please volunteer for
Or I just have a strobe, normal strobe video. If in this we can just
अगर volunteer कोई कर रहा है तो
है ना, so Olympus वाला volunteer करेगा ना? He wants to sell. You want to do it? करे?
consent
Verbal consent take. Yes.
कर लो ना so that it becomes more of a live
Do we have time again? We have time. 2 minutes to go. Most time, yes, it is in standing position, and generally I would like to have a slightly height of the patient slightly higher at my chin level. That will give you better idea. And monitor should be on the left of the patient. Generally, it gives a good view of the area. Yes, E. As we see, is around 121 is the which is the normal male conduct frequency. First, if I report this F0 120 between 114 to 120. We go inside. So we assume I have taken consent of the patient, I have explained the patient what is to be done, and I have sprayed some lignocaine as I have told you. We go inside the nose. This should be held like a pencil because this is the initial. Problem is crossing the nose, not the oropharynx or the nasopharynx. Once you reach the nose, but when I am in the nose, we tell the patient to breathe from the mouth. Keep the mouth open and breathe from the mouth. And now I am very, very close to this area. As I go inside, keep breathing from the mouth. Keep breathing from the mouth. Now I have reached the nasopharynx. At this stage, we tell the patient to close the mouth and breathe from nose. Wait. Now we'll breathe from nose. Now this is a stage where patient has, this was a phase where he was not comfortable as we pass something from the nose. Now his comfort level will be more, but at this stage, wait for a few seconds. Let the patient understand what has happened. And now he has to breathe from nose because we want to see the palatal movement. So now he breathes from the nose. We are seeing the posterior pharyngeal wall. We take an option to area to see the eustachian tube opening. We can see a fixed posteriorly. As I go down, now we are seeing some revelations present, might be just because of some reflux changes. In the quality of camera, we can see the capillaries also almost very nicely. Again, I am not promoting any processing. I am just seeing the quality. Here I have to see the base of tongue. Now, where we are analyzing this at the same time. Any patient having OSA, we will analyze the base of tongue. We will see the tonsils on both sides. As I go down, the glottoepiglottic fold, the vallecula, and now the epiglottis. So now we can change the scope. Keep the mic. Right, now we are into stroke mode. As I go down, now first is at the level of epiglottis, I will see the entire vocal cord. Now see, I am not going further down, which I should ideally because we will have some cup reflex because you are not clear at all. Now say So point long. Now you see that when he is saying this higher pitch, the vocal cords are getting stretched, they are getting elongated. Again, high pitch and when he is saying we just saw mucosal mucosa secretion coming on his left vocal cord. Again, say This means the effort that he has taken is much more than what it was by normal phonation. Now say normal low pitch. In this the vocal cord has become narrowed. Now the idea low pitch. Yes. So the idea is we need to, why are we doing all this? We need to see the upper lip, the middle part and the lower lip. All the three lips should be seen, only then the complete assessment should be done. At this stage, I will ask him to record the video, I remove the scope and then analyze and remove the scope. Shall I remove the scope, sir?
Yeah.
I remove the scope. You should thank him because without spray he has completely operated well. And you should thank me for my skill also. Okay. And so, sorry, our aim is to see the upper lip, the middle lip and lower lip, all three of them together, record this thing. We cannot do all an assessment at one point, and always good to have three doctors assessing the same view. In what we do in institute is speech therapist, my junior and myself, we all three assess it in different way and then we see whether it is matching or not, because amplitude, symmetry, periodicity is slightly subjective. This is the place for youngsters AI should get in. AI should get in where we feed these findings and AI should report us what is periodicity, what is symmetry, what is amplitude. A very good way in which we can research tool which is there. I thank organizers for giving me the opportunity for making stroboscopy. Any more doubts? Yes, thanks.
Thank you so much, sir, for the wonderful session. I request Chairperson to felicitate Dr. Prasun Mishra, sir.